we do have the press release out there telling us that CONTACT-03 is a negative study, and we have not seen the data yet. And the devil is in the details, right? Because it's a lot you can learn from it. So I think when CONTACT-03 was designed, and by the way, I do like to highlight TiNivo-2 in addition to CONTACT-03, those are the two phase 3 trials asking the similar question, which is there a role for checkpoint inhibition in the salvage setting for patients who have progressed on a prior checkpoint? That's really what they're trying to ask. And they were designed in a different way. You know, CONTACT-03 uses atezolizumab as the backbone PD-L1 inhibitor, and it compares, again, one of the most effective TKIs out there, cabozantinib. Is using full dose in both cohorts, and the study is negative. And is negative as far as, you know, for PFS, meaning, you know, patients, as far as we know, at least for the primary endpoint, patients on cabozantinib monotherapy did not do worse or did not progress sooner than patients on cabo plus atezo, which is a very important piece of information. TiNivo is asking something similar, but he's doing tivozanib with nivolumab, standard dose of nivolumab, which is a PD-1 inhibitor. Again, patients who progress on a prior checkpoint were eligible up to 2 prior lines of therapy. And you have tivozanib, which is a novel TKI being investigated here or studied. The difference is you are going with the lower dose of the tivozanib when it's combined with nivolumab. So you're comparing it against full dose of tivozanib 1.34 daily. So some nuances about the design. What is my take on CONTACT-03 being negative? Well, I guess the easiest answer or the easiest thought to have about it is there's no role for immunotherapy in the salvage setting. We kind of knew that, by the way, or we kind of got that information for all the studies investigating ipilimumab in the refractory setting beyond frontline. And now we know, you know, with responses between 10 to 15%, that using ipilimumab later on, it's probably reserved for selected cases, and it should not be done as for the vast majority of patients because it doesn't quite seem to help them. But that might be a different answer for, you know, PD-1 and PD-L1 inhibitors. So CONTACT-03 being negative tells you probably it's not a good idea either. However, I think the devil's in the details because we have not seen anything about who are those patients from different perspectives, right? Like, you know, we have the sense that the sooner you progress on a checkpoint and you go on another checkpoint, you're less likely to benefit from it, right? Just common sense. So because you can have primary progressors on there versus secondary progressors, right? It has to be different. A patient has been on a checkpoint with benefit for 2 years versus one who progressed on a checkpoint for 3 months. And by the way, there was no exclusion criteria, the duration of prior checkpoint. And I think that's actually an important question. We don't know that, right? We also don't know at the molecular level, you know, who are the patients on this trial? Are they prone to benefit from an angiogenic drug more than they are with immunogenic drug? Does it matter the presence of immunogenic signature? We don't know that, right? Does it matter the location of mets? You know, does it matter the presence of sarcomatoid rhabdoid features for patients enrolling on CONTACT-03? We don't know any of this, right? Do we know what treatments they got upon progression? We also don't know that because we haven't seen the data. So I would argue that, yes, it's a negative study, and I do believe it's going to give us a lot of pause considering an IO-based approach beyond progression, upon progression or prior checkpoint. But I won't forget that this data was developed post very preliminary, interesting data, phase 2 data, including LAMP-PAM data, that, you know, with responses over 50%. Now, yes, it's a smaller study, you know, single arm studies, selected group of patients, you know, and I'm thinking, for example, of the data from Sloan with LAMP-PAM specifically. But I have, you know, and so we have to understand as we think about this through and we have more data, is there's really a synergistic effect of an IO-based approach, or what we're getting is an additive, you know, result of, you know, what are you getting with a checkpoint and what are you getting in a TKI, and you combine them. So I don't think we know that for a fact. In addition to that, we don't know if there's a difference between a checkpoint or a PD-L1 inhibitor with a PD-1. The bar was high because compared with 60 milligrams of cabo is a high bar, right? It's the only, you're using Meteor data to support the use of cabo as monotherapy. So I'm just going to say with caution that for now, I think once we see the data, it will probably give us some pause about the role of checkpoint inhibitors in the refractory setting. I don't think the story is over. I think there's more lessons we'll learn from TiNivo, and if or whatever happens with TiNivo, if it goes in line with CONTACT-03, certainly that would make the case against the systematic use of a checkpoint inhibition in the salvage setting. If TiNivo happens to be positive, that might give us more questions than answers. But that's how we evolve, right? That's how we learn. So I don't think we're settled on that question yet. I think definitely we might be a little bit more reluctant, today than prior, than before the press release came out.